Hello, everyone, and welcome to tonight's webinar where we'll be talking about a major shift in autonomic and autoimmune treatments, and specifically talking about engineering cellular immunotherapies. A lot of what I'm going to say tonight is based on a Nature Biotech publication that was published sometime in February of this year. I will refer to it in a couple of minutes and specifically tell you when I do that. But first, some basic terminology there. So, immunotherapy means using the immune system as the treatment tool, essentially. And cellular immune therapy means that the treatment is made of living immune cells and not as opposed to a drug or chemical or a molecule like that. And of course, if we engineer it, that means that we modify those cells using genetics, usually, so that they do something new. So traditionally, we manage autoimmune disease by immunosuppression, which is a sort of broad reduction of immune activity using steroids or other agents like drugs and chemicals. And these can be life-saving, but they're often chronic and non-specific and come with infection risk, as well as malignancy risk or even organ toxicity. So the approach that we're going to talk about tonight is not actually exempt from any of those, but it is an alternative. And so we're covering it because it is different, and it's essentially the program the immune system to remove or control specific immune cells that are driving disease, or potentially enabling a durable remission. So if you think about autoimmunity, right, the ground basic, so to say, autoimmunity means that the immune system mistakenly targets the body's own tissue. So it's the core failure is essentially a loss of immune tolerance. Tolerance is sort of the normal don't attack self training outcome. And there are two types of cells in autoimmunity that show up a lot and are going to recur a lot throughout tonight's discussion as well. The first one being B cells or beta cells. These are immune cells that can produce antibodies. An antibody is a protein that binds to a target, all right? And in autoimmunity specifically, they can produce auto antibodies, which are antibodies that bind to the host's own cells. So that's the one, B cells. And the other one is T cells. So the T cells are immune cells that coordinate immune responses and essentially kill whatever they bind to through a process called cytolysis. So T cells are the killer cells. They find the cells and then they kill them. And you'll also actually hear the term cytokines come up quite a few times. So these are chemical signaling messages, and they essentially they're these messages that cause the actions to happen, and they amplify things like inflammation, although they can actually dampen it as well. But they chemical signals that are also involved in immune system functions. So the big idea, right, is if we can precisely remove or retrain the immune populations driving diseases, and we may be able to achieve remission without permanently having to suppress the entire immune system. And that's where something called cell therapy actually comes in. So cell therapy has the broad sort of idea is you collect immune cells, say from the blood, and then you grow them. So you cause proliferation of some sort, and then in this specific case, you would engineer them. So you would add a new function of some sort, and then you would infuse them back. So take them out, engineer them, grow more of them, put them back. That's the basic pipeline. Now there are two clinical terms that are quite important in that whole system. The one being autologous. So this means that the cells come from the patient themselves. So that's, yeah, like I said, that if you take it out of the patient and grow it like that. So and it has some advantages. The advantage being that you're less likely to have an immune reaction or a rejection of the cells because it comes from the host itself. But the big obvious disadvantage is that there's a limitation in manufacturing time and quality because it depends on on what the patient has to work with to start off with. Uh, and yeah, and you do need to harvest that from the patient itself. The other type or term that comes up a lot, that is sort of the antithesis to autologous ones, is allogenic. So allogenic means that the cells come from a donor, or, and this is important, a standardized cell line. So sort of a more off the shelf approach. So you can actually grow cell lines, and these can potentially be uh, treated into the patient as well. And so the advantage is that this is scalable. This can be produced. It's faster, more consistent. But the limitation with this is, of course, that now you stand a much bigger chance to elicit an immune response, because if there's an immune mismatch, then you can see an immune rejection. But so let's talk about a couple of those sort of in plain language, right? So the main one, the biggest one, is something called CAR T cells, right? So CAR T stands for chimeric antigen receptor T cell therapy. Chimeric just because it's built from multiple parts. It's a fusion molecule. And antigen, like I said earlier, is just the target where the molecule actually, or the target that it can recognize and bind. So if you remember from COVID, the target protein there was the spike receptor. So the antigen in COVID bound to the spike receptor. So, and receptor is actually also an important term to know. So receptor is just the sensor that recognizes the antigen. So an antigen and a receptor are the two things that bind together, and that's how they essentially find the target molecule. And then the T cells are the patient's own immune cells that then come and kill the cell there through cytolysis, like I said earlier. So essentially, the CAR T, this whole chimeric antigen receptor T cell therapy, is when we give T cells a new sensor, all right, a new receptor, essentially, so that they can recognize any chosen target on any cell that we give them, and then kill those cells specifically. Now, um, there are three, maybe five functional regions when you talk about the CAR system. So the first would be the outside, the ectodomain, as they call it. So outside of the cell, this is where it actually binds, and it's often derived from an antibody. So antibody would be the target that binds with high specificity. Then you have the transmembrane domain, the middle, and this is the anchor passing through the cell, so the membrane, it's like the stalk for holding the sensor in place. And then, as you may have guessed, you have the intracellular domain as well. So that's inside of the cell, and this is the wiring of it all, and it signals the turn that, or the T cells go turn on and expand and persist and ultimately kill the cells that they bind to. And there are actually two important types of domains as well. That's why I said three or five. So the one is the activation domain, the sort of go signals that triggers the cell killing, the cytolysis is the technical term. And then there's also something called the co-stimulatory domain, right, which is more of a quantitative sort of signal. It says how long does it need to be triggered, or how much. Yeah, so it sort of, in a way, kind of controls the level of the response. So let's take it from there. So when the CAR actually binds to its target, right? So you've in these domains that I just described. So what happens then is it proliferates. So it makes more, it multiplies. And so after infusion, you have a lot more of it in circulation. Then it performs this cell killing, the cytolysis, and it destroys all the target cells. In let's say you work with a specific disease and you want to identify that disease, it's now bound to that cell, and it's destroyed those cells specifically. And then it does something interesting, which the natural immune system also does, is it forms a type of memory. So you get, in the immune system, you get something called memory T cells, which are longer lived versions of the cells. So, and the biological function for that is, if you say it's a virus and you get infected with the same virus again, these memory T cells actually do recognize it again, and you can much easier identified, and they send the T cells to destroy this invading this invading principle. And so that using that, you can actually, it's the same thing. So if you induce infuse the CAR T cells, it also forms memory T cells, and next time it will destroy it again. So clinically, this is why CAR T is different from any drug, because it can actually it works like a living treatment that expands in the body and has, at the very least, theoretically, these prolonged effects because of the function of the memory T cells. Now, earlier I mentioned the two types of cells, um, or the yeah. So and the but the important one there is, or probably the most important one there is the B cells or the beta cells, because they contribute to autoimmunity in quite a few different ways. So they are the cells that produce the antibodies themselves, the self-reactive antibodies, and they do the what's called the antigen presentation. So they essentially show the pieces of the antigen, or they make it identifiable by the proteins of the T cells. So yeah, without the beta cells, it wouldn't be possible for the T cells to identify them and bind to them and cause um, uh, cell killing, cytolysis. But and they also secrete what I also mentioned earlier, cytokines, and so it's this signal molecule that also makes it identifiable and makes the autoimmune system escalate into an immune reaction that eventually kills the cell. So those are the ones. So it's the B cells, and this whole using the B cells as the target cell for where the T cell binds and activates and does its thing. So B cells and T cells. So, but in the B cell itself, there are different types of markers. So there's surface level markers, there's more internal markers. So one of the most common ones is a marker called the CD19 marker, and it's pretty much expressed across the entire B cell. And what it does is it's a pretty broad one, so it depletes quite a few B cells. It depletes many B cells. But the because it's like, if you talk about cell lineages, it's expressed in a very broad number of these lineages. So it's a very broad application. If you target this one, it's going to target many of the B cells. A different type of cell that's also a B cell is a plasma cell. So this is a more mature descendant of a B cell, so that secrete antibodies. So there's a term called BCMA, which is B cell maturation antigen, and it's these are markers that are mostly associated with plasma cells, the ones that I just spoke about. So what this essentially means clinically is, if you look at the B cell, you can't just target the specific or any part of it. There's, depending on the disease, depending on the phenotype, you want to be targeting specific parts of it. So, for example, if your disease is mainly driven by B cells in their sort of most active phase, their ongoing activation, then CD19 would be the target on the B cell itself that you design your CAR T cell therapy towards. But if it's a more long-lived antibody secretion thing, then you would be targeting the plasma cells, which means you'd be targeting BCMA. And but with all of these, there's different pros and cons. So you can also remove a sort of the protective antibody effects, the long-term protective antibody effects that you get through memory T cells if you target the mature plasma cells, because it does take away those ones. So it does come with pros and cons depending on what you actually decide is your target region, and it does very often depend on what is the clinical diagnosis and why would you use one type of target versus another one. So I spoke about a Nature publication, a Nature Biotech publication. So there's this the reason I spoke use it because it's a very good example of where they took these CAR T cell therapies and applied it to lupus. So essentially what they did, and yeah, so essentially what they did is you with lupus, you have these different domains in which you can see whether the disease is in remission or refractory. Remission being the symptoms are being expressed less, and refractory meaning it's not responding to standard therapies. And specifically in the case of lupus, there's the one scale was called the SLEDAI, SLEDAI scale. Don't know, I don't remember what it stands for, but it was a score from zero, and zero being that there is no active features. And then there was another one, which is a more phenotypic assessment, which was the LLDA, which was the lupus low disease activity, which is another way of quantifying how severe is the, or how low is the activity state of the lupus. And so, this Nature Biotech review, what they did is they did a CAR T cell therapy approach, um, and what they saw is that the activity rates on this quantitative scale decreased. So you saw, especially, in fact, they specifically noted, especially among severe treatment refractory cases. So it's important. So it's promising, in short, but it's also important to know that these results are quite early on. It's quite preclinical. Um, or it's clinical or early phase clinical. I'm actually not sure. But the point is that there are no randomized controlled trials as far as I know yet. But it is a really good direction to go into, and it does show promise to these CAR T cell therapies. Uh, but before you sort of order your CAR T cell therapy kits immediately, you have to realize that there comes all sorts of safety concerns for the clinician, of course. So, one very big safety concern when it comes to these types of therapies is something called CRS, which is cytokine release syndrome. So, uh, cytokines, like I said earlier, are these immune messenger proteins. So CRS happens when you have too many of these immune cells that activate all at once, and so they release in a sort of burst of cytokines, like an immune storm, right? And so what happens then is if you have all of these cytokines that releases phenotypically or clinically, this presents as something that looks like a fever. Um, uh, and if it's very, very severe, you can get hypotension being low blood pressure, so all the doctors know, and hypoxia, low oxygen, cellular oxygen. So, and you'll hear CRS is actually also described in these grades. So grade one is, or these scales and levels. So the grade one is usually mild. It's maybe a mild fever, mild symptoms, that type of thing. Whereas the higher grades, are the ones with hypoxia, where you need to put someone in the ICU because they have low blood pressure, they need blood pressure support, they have oxygen needs, etc. So, um, and actually, come to think of it, on the risk of that Nature Biotech one where they looked at the lupus, what they find is that there was actually quite frequently cases of CRS, although they did also note that it was quite mild most of the time. But yeah, it's an important safety concern. The other very important safety concern when it comes to CAR T cell therapies is neurotoxicity. So specifically, there's something called ICANS, ICANS, so which stands for Immune Effector Cell Associated Neurotoxicity Syndrome. Immune Effector Cell Associated Neurotoxicity Syndrome. So essentially, what this means is it causes confusion and language problems, and in some very rare cases, even seizures. So these immune effector cells means that or refer to these sort of engineered, the ones that you took out and engineered and then put back in, and then it causes this neurotoxicity effect. So it means adverse effects on the brain function, neurotoxic. Yeah, and like I said, it presents as confusion and trouble speaking, and then in very severe cases, it can be seizures or maybe even loss of consciousness. So, and of course, when it comes to neurotoxic side effects, it's not a case where you sort of sit and wait. So post infusion, you kind of follow established cell therapy toxic pathways, and involve treating the cellular therapy team very early on. So it's a rare but very important case. So CRS and neurotoxicity are two potential side effects or risks of CAR T cell. Even though we do see the data is showing, okay, it was good in this one disease, that we tested that can we use the immune system itself to try and combat the disease, but it does have risks. And another risk, so apart from CRS and ICANS or neurotoxicity, is something called hypogammaglobulinemia. Globulinemia. It's a mouthful. So hypogammaglobulinemia, um, which refers to the immunoglobulins, so the antibodies that you find in the blood. Hypogamma uh, Hypogammaglobulinemia um, essentially means it's like any anemia. It means that you have low levels of these immunoglobulins. Um, yeah, so anemia is low levels of erythrocytes, but it's a low level of this specific type of thing that you find in blood. And if there's a low level of these bloodborne antibodies, that means you're at higher risk of infection. And so we spoke about the different cell targeting. So in the case of the BCMA, which target the more mature cells that are found in the plasma, um, that one is actually more related to this hypogamma globulinemia as well. So yeah, and then yeah, so just to reiterate, so gamma globulins are these are largely these immune globulins, which is just the technical term for an antibody that you find in the blood. There's a couple of different ones of them. But there's a few different ones of them. But the anemia or the anemia part of it just means that the levels of this has dropped. And if this is the case where the antibodies are low and your susceptibility to infection then as a result becomes high, you might need an IV. So specifically an IVIG, of course, which would be an intravenous immunoglobulin um, insertion. So, which is which where you have antibodies that are given as a replacement. And so the Nature review did mark on that as well. And so essentially they said that in the case that you have an approach which targets plasma cells, so that's the BCMA targeting strategies, um, it's more likely to reduce vaccine-derived immunity and cause this specific potential risk. So hypogamma globulinemia, compared with approaches that primarily deplete the beta cells as opposed to the BCM. So the more active component of the cell rather than the BCMA. So which would follow the CD19 CAR T cell um, pathway. So, but beyond the BCMA CAR T, right? So, beyond the CD19, you have these BCMA CAR T cells, um, and what they do is they BCMA essentially because the reason you're targeting the mature antibodies is because you're also essentially targeting the antibody factories, which is especially relevant when you're talking about sort of long-lived antibody secretion, which is driving long-term diseases, right? So it's useful in the case that you if you want something that specifically targets something that has a more long-lived antibody secreting disease, then this is great because that targets that specifically, but it does have its own obvious trade-offs as well, which is if you remove the plasma cells very broadly like this, you may also actually remove the protective antibodies that are generated from, say, past infections or past vaccinations. So yeah, so BCMA target shifts this sort of clinical emphasis towards immunoglobulin monitoring and infection prevention and replacement strategies if these become too low. So it's you're kind of trading one ailment for another, but it depending on the disease, it might be much less dangerous. Uh, I've been talking a lot about the CAR T cell precision. So just an interesting little thing. So there's something called that's also called CAR T, but spelled with two A, so CAART, um, which is also in this realm, but it's a different thing. So it's called that's the double A stands for auto antibody. So CAR as in double A would be chimeric auto antibiotic receptors. Um, and and so essentially what this is, instead of the antibody like binders targeting CD19, this thing would be an autoantigen. In other words, it's a self binding protein. So instead of targeting the disease, it targets it can target itself. So yeah, so but it can also be designed, it can also be engineered. So if you take one of these, that's a CAR, as in double A T cell, where you have the auto binding ones, you can still target B cells whose B cell receptors, so the surface proteins, recognizes the specific autoantigens as well. So you can still engineer it to target the specific cells as well. And so in the specific case clinically, so this means that the disease, actually it has a very, very useful clinical application, because when you talk about antigens or autoantigens, or there's actually quite a few less autoantigens. So if you're designing something that specifically targets an autoantigen, it's actually a lot easier to use or to create the sort of bait molecule, the one that it targets or binds to, because there's fewer to select from. So it can actually be quite useful in terms of a precision tool, to target autoantigens as opposed to antigens. But yeah, anyway, I just thought I'd speak a little bit about the CAR T with the two A's, the chimeric autoantigen um, receptors. So yeah, so just on the T, so the T being the regulatory T cells or T cells. So you get another type of T cell called a regulatory T cell, or sometimes called a Treg cell, so Treg. Uh, and what they do is they kind of like the brakes for the immune system. So they suppress autoimmune inflammation, as opposed to all of these other ones, the regular T cells that cause cytolysis. So they don't kill the cells; they just cause, reduce inflammation. And so this is a different branch. So the regulatory T cells, as opposed to the killer T cells or the memory T cells, or as I said, regulatory T cells can be shortened as TREGs, and they're more a break rather than a kill switch, which is also something that can be implemented. So instead of deleting the B cells, the idea would be to engineer these cells, to the TREGs, to suppress inflammation in a very sort of targeted precision way, as opposed to sending it out and killing the cells there, which is another interesting avenue to explore. And so a crucial concept there would be that in this case, you'd be looking at phenotype or phenotypic stability. Phenotype, as you know from all of the genetics talks that we've had, just means the sort of functional identity, what you see, what it behaves like. That's the phenotype. So if a regulatory cell loses its regulatory identity, um, in an inflammatory environment, it may completely stop working, or worse, even worse in the whatever disease you're looking at. So, and lupus in the case of the Nature publication. And so that's why these modern strategies actually focus on making the the regulatory programs stable, right? So that would be an alternative to using killer T, which can be quite a dangerous tool, especially if you have all of these cases where it binds to the wrong places or to itself, and kills the wrong things and causes these side effects and neurotoxicities and so forth. So instead of having all of that, you had these cases where in theory, you could make one that's only a break, that only targets inflammatory responses. So it's a safer alternative, in theory. uh, yeah. So anyway, so that's kind of a little bit of an update on all of the different CAR T cell related therapies, because we did speak about CAR T quite a few times in one or two of the other webinars, and I just thought we should focus a little bit on what that is and how it's implemented. Um, and yeah, I mean, clinically, you might wonder, okay, but okay, now that I know about these four, what do I actually choose? What is the practical decision drivers? So the clinicians would know that there's a process called lymphodepletion. So which is actually chemotherapy based. So chemo is used to temporarily reduce the lymphocytes, and this makes it easier to when you introduce these engineered cells, that they can be that they can express, expand, and be persistent. Um, but it does actually also add a toxicity risk, so cytopenias or infection risk, that type of thing. So before infusion, many of these protocols, the technical term for anything like this is called preconditioning. So some protocols use this preconditioning in the case of CAR T cells, which would be, like I said, lymphodepletion, because it targets the lymphocytes, where these cells, the B cells and the T cells that we've been talking about that are related to the immune system, are made. And yeah, and so the chemo would deplete these, and this creates a space for a more supportive cytokine condition, for infused cells to expand and persist, like I said. So yeah, so that would kind of be the method of introduction, is you lower the lymphocyte, or yeah, you target the lymphocytes, and then you are able to introduce these new cells, because the immune response is not going to be so intense, or the risk of side effects. But you still have other side, because you did this, of course. First of all, it's chemotherapy based. It comes with many side effects, but clinically, there's actually the additional risk as well of cytopenias, which is cytopenia is just a so it's a low blood count, um, or neutropenia, for instance, which is a low level of neutrophils, which raises, once again, like the antibodies being low, it raises the risk of infection and any sort of anemia, or thrombocytopenia, or any of these sort of lowering of bloodborne um, carriers for these type of things, like immunoglobulins. So yeah, but anyway, so preconditioning is one of the biggest sort of levelers in balancing the efficacy and toxicity when you do these CAR T cell therapies. Uh, but it is all of these therapies, even though the results are promising, it is still early days. Um, I think early clinical phase, preclinical, even somewhere around there. But it is very promising, and so these therapies are not. Just to clarify, they're very different from immunosuppressants. They're not stronger immunosuppressants, or anything. They're a completely different thing. So they essentially use the immune reprogramming with living cells, so the own immune system, to try and fight all sorts of different diseases. And so we spoke about just a handful of the target regions. We spoke about the CD19, which was the broad B cell depletion strategy. We spoke about BCMA, which is the mature sort of plasma cell based ones that target the antibody factories themselves. We spoke about CAR with two A's, the chimeric autoantigen receptor. So that's the antigen specific removal, of the autoreactive beta cells. We spoke quite a bit about the different toxicities, so the side effects, the CRS, neurotoxicities, infection related things, to lowering of different bloodborne things like the immunoglobulins, that mouthful word, the hypogammaglobulinemia, and how it's sort of a trade off, and it becomes more a monitoring of immunoglobulins in the blood, um, to try and mitigate risk. And then we also spoke a little bit about the early clinical signs being exciting, according to some recent publications, like the one in February from Nature Biotech. But we still need quite a lot more standardized tests and endpoints and outcome measures, and follow-ups and longer-term follow-ups for clearer predictions. But yeah, it's a really promising start. So if you're a clinician who may in the future refer patients, the highest yield skills would be recognizing who might benefit from something like CAR T cell therapy, and understanding the basic potential risk, and also communicating the basics of these therapies accurately, to the patient, if they may ask, well, what is this CAR T cell therapy that I've read so much about, and that seems to have all of these promising results. So now you can give them a little bit of a background of what it is, how it works, how it targets the B cells, um, and how it or incorporates the B cells and the T cells, and it sort of works on the body's natural immune system to try and target and eliminate cells, or in the case of the regulatory T cells, suppress inflammation markers. So yeah, and that's a pretty decent background on the theory behind CAR T cell therapy to start off with. So yeah, that's all that I have for you tonight. I saw one question which was, is CAR T cell therapy just for cancer? And not doesn't have to be. So I often say on these workshops that on these work webinars that cancer is kind of like the frontier to a lot of these tools. So a lot of these tools start out in the fields of oncology or any cancer related research. Um, but if the cells are, if you can design a mechanism that targets the cells, a specific type of cell, there's no reason why it should only apply to autoimmune. Uh, it's still, sorry, only apply to cancers. It can apply to or any autoimmune disease if as long as the driver cell is identifiable. So if you can create the system or make sure that the system is able to identify, like the CD19 would be the identifiable marker, um, then it's fine. Then you can use it. So there's no reason why CAR T cells are only for cancer therapies. In fact, there are examples preclinically that are not cancer that also use this mechanism. Although it is, and I understand why the question is asked, because we had previously spoken about this in in the context of cancers. Um, but yeah, no, it doesn't have to be specific to cancer. But yeah, so if that's the only question, then that's actually all that I have for you tonight, and I hope it gave you a bit of an understanding or bit of a background. I also have a little bit more of a understanding of it all now, but as I always say, I am fallible and may have made mistakes, and if so, by all means, point it out, and I will try and correct it next time. But with that, I bid you adieu, and yeah, thank you for joining us this time. And I hope I see you in the next one, which I myself am not sure what it's going to be on just yet. But I will see you guys there, and yeah, pleasant night further to all. Cheerio.